Hello guys, welcome back to Clinically Clear. Today we'll be covering another topic, one of it's sort of a developmental disorder, but not exactly. You will get to know what once I continue teaching it. So let's start. Amblyopia. Now, what is amblyopia? Amblyopia is also commonly called as weak eye. Weak eye because one eye is said to be weak compared to the other. So let's get into it. So let's first define it. Reversible partial, unilateral or bilateral loss of vision due to abnormal binocular interaction during critical period that cannot be attributed to any physical deformity in eye or visual pathway. Let's break it down. Reversible. When is it reversible? Only if you treat it early. Partial loss of vision. It can be unilateral or bilateral, but most of the times it is unilateral. One eye is very weak, one eye is strong. Most of the times it is unilateral. And it is due to abnormal binocular interaction. What is binocular interaction? Basically, we have two eyes, right? Two eyes forming two images. And these images are fused at the level of visual cortex to form a single image. That interaction is known as binocular interaction. So that abnormal binocular interaction during critical period. What is critical period? It is the initial years of life, from birth till about 7 to 8 years, where the development of visual network is taking place. And so this cannot be attributed to any physical deformity or any, like, not a refractory error or anything like that. It can be due to refractory errors, but it is not due to physical deformity, but it is due to a reduction in the visual neuronal network pathway. It sounds a bit confusing. I'll explain it much better later. So what are all the risk factors? Now it could be due to now it can be seen in low birth weight babies, premature babies, children with delayed developmental milestones, cerebral palsy, mental retardation, and etc. So next, coming to the pathophysiology. Basically, as I told, there is a critical period from birth to about 7 to 8 years, especially the first 3 years. At this stage, there is maximum neuroretinal development or plasticity, where the neuroretinal axis is developing. So during this period, it is important for visual cortex to receive equal and strong visual input from both the eyes, so that normal vision and normal binocular interaction during this developmental period, critical period, both the eyes should send equal and strong visual input to the visual cortex. But when there is unequal input, where from one of the eyes there is a weak or abnormal visual input for a prolonged period of time, then what happens? The visual cortex, it will prefer the input only from the strong eye. This weak and abnormal visual input, it will ignore. So it will prefer only from the strong eye. So the weak eye eventually becomes amblyopic. And it is important that it is for a prolonged period. Now, if I close my eye for a minute, there is no visual input from this eye, but there is visual input from this eye. So does that mean my visual cortex will prefer only this eye? No. No, this is for a very short duration. But when this unequal visual input from both eyes is for a prolonged duration, then what happens? The visual cortex prefers the input from the strong eye. So next, coming to the neuronal basis. Now, neuronal basis is a bit complicated. I'll simplify it. Basically, in our visual cortex, there are certain neuron networks known as ocular dominance columns. And these ocular dominance columns, they are responsible for interpretation of the visual input from both the eyes. Now, as you can see, in a normal 6-month-old with normal visual input from both the eyes, the ocular dominance columns of the right eye and the left eye, they are all of equal size. But here you can see in yellow color, which I have labeled, where the left eye has gone into amblyopia. So what has happened? The visual input from the left eye is much weaker than the right eye. So what happens? Our visual cortex begins to prefer the right eye visual input. So as you can see, the right eye ocular dominance columns are very, very big, whereas the left eye ocular dominance columns are small. So larger on the right and smaller on the left. So this is the neuronal basis. So this is about the pathogenesis and the pathophysiology. Next, coming to the visual defects in amblyopia. Basically, the visual acuity decreases. Now, obviously it will decrease. Why? Because one eye, there is no visual, the visual input is not considered, whereas the other eye it is considered. So, but when we look at the best correct BCVA, what's BCVA? It is best corrected visual acuity. Basically, when you go for an eye checkup, they put those lenses in front. They put multiple lenses to try and correct your visual acuity and then see a visual acuity. Even after correcting it, in amblyopia, between the amblyopic eye and the sound eye is basically the normal eye, there is a minimum of 2 lines difference in the Snellen's chart. So basically, with the sound eye, they'll be able to read 2 lines below, 2 lines that are like with better visual acuity, whereas with the amblyopic eye, even after correcting the visual acuity as much as possible, they're not able to read that line. So there's a difference of 2 lines. And if I have to grade the amblyopia based on the visual acuity, mild amblyopia is from 6/9 to 6/12. Moderate amblyopia is from 6/18 to 6/36. Severe amblyopia is anything more than 6/60 or 6/60. In amblyopia, color vision is relatively unaffected. The fixation pattern can be either central or eccentric. Now, eccentric fixation is a problem. Now, what is fixation? Basically, see, the light rays that pass through our retina, they normally get fixated onto the fovea. This is known as foveal fixation. But if it is getting fixated onto the eccentric part of retina, that is the peripheral part of retina, then that's a problem, right? That is one more visual defect. Then, effect of neutral density filter. Now, what is neutral density filter? Now, neutral density filter is something that reduces the amount of light that passes through it. So, let's say this is a neutral density filter. It obviously reduces the amount of light passing through it. If I place this neutral density filter in front of my normal eye, then obviously the visual acuity will reduce. Why? Because the amblyopic eye visual input is not being considered by the visual cortex. But if I place this neutral density filter in front of my amblyopic eye, then the visual acuity remains same. It does not further decrease, because irrespective of whether this blocks light or allows light to pass without the density filter, the visual input from the amblyopic eye is anyways not considered by the visual cortex. So it does not matter. Already the visual cortex suppresses the visual input from the weak eye. So even if I place the neutral density filter in front of the amblyopic eye, the visual acuity remains unchanged. This is one more visual defect. Then there's another thing known as crowding phenomenon. Now, what is crowding phenomenon? Crowding phenomenon is basically, if I take a letter, example in a Snellen's chart, all the letters are placed very close to each other in extreme proximity. So let's say I ask the child to identify a letter in the middle. Then the child is not able to identify the letter because he or she feels that all the closely spaced objects are crowding next to each other. This is because of abnormal binocular interaction. Again, as I told, amblyopia is a disorder in which we have abnormal binocular interaction. But same letter of same size from the same distance, if I take on an empty sheet of paper, child is able to identify. So when you have multiple closely spaced objects, then there is crowding phenomenon. This is another visual defect. Next, coming to the types of amblyopia. First of all, the most common type is strabismic amblyopia. What is strabismus? Squint. Under this, esotropia is more common than exotropia. Esotropia is basically inward squint. Exotropia is outward squint. So, what happens here? Think about it. Due to misalignment of the visual axes, where basically you have two visual axes, right? Normally they are aligned. So if I'm moving this way, they'll be aligned this way. If I'm moving this way, they'll be aligned this way. What happens is, because of strabismus, there is misalignment of two visual axes. So the visual input from this eye is different from the visual input from this eye. And at the level of visual cortex, these two visual inputs are not compatible. They are non-fusible. So because they are non-fusible, there is abnormal binocular interaction. This leads to competitive inhibitory interaction. Now, what is competitive inhibitory interaction? There is one fixating eye. Let's say this is the strabismic eye, which is undergone paralytic squint. This eye is fixating. Wherever you want to see it is fixating. So, this fixating eye visual input dominates over this non-fixating eye visual input at the level of cortex. So, chronicity, over a prolonged period of time, what happens? This prolonged competitive inhibition of the fixating eye over the non-fixating eye will lead to amblyopia of the non-fixating eye. So that is why strabismic amblyopia is the most common type of amblyopia. Second most common is the refractory amblyopia or anisometric amblyopia. Now this is simple. Now both the eyes have refractory errors. But what is anisometropia? When the refractory error of one eye is different to the art of the other eye. So let's say the difference is at least 1 diopter or more than 1 diopter. Then what happens? One eye with with less degree of refractive error will produce a clear focused image, whereas just a minute, yeah, whereas the other eye with the weak eye with the higher degree of refractive error will produce a blurred, distorted image. So what will happen? Eventually, over a prolonged duration of time, our visual cortex will also prefer the clear image, the focused image. So the weak eye producing the blurred image will go into amblyopia. So that is because of difference in refractory errors. And in this also, anisohypermetropia is more common than anisomyopia. One thing to remember. Now, refractory amblyopia is the second most common and it has the best prognosis. Why best prognosis? Simple. Just correct the refractory errors, and then when you correct the refractory errors, then what will happen? There will be, when you correct the refractory errors, both the eyes will produce a clear and focused image. When both the eyes produce a clear and focused image, then no need for the visual cortex to prefer any one of the images. So just correct the refractory errors in both the eyes, make them both have the same refractory power, then you can prevent this refractory amblyopia, or you can reverse it if treated at an early age. Next comes organic amblyopia. Now what is organic amblyopia? Organic amblyopia is irreversible. Yes, it is due to any organic brain pathology in the visual pathway. Example, because of toxic alcohol amblyopia, they say, toxic lead amblyopia, arsenic poisoning, lead poisoning, alcohol poisoning. These all cause some organic lesions in the visual pathway that lead to irreversible amblyopia. Let's say right eye optic nerve, there'll be some lesion, and right eye visual input will not be considered, right? Like that. Last type is form deprivation amblyopia. Now, form deprivation amblyopia, it is the least common and it has very poor prognosis. Why? Now, let's look at under form deprivation amblyopia, we have three further subtypes. First of all is sensory deprivation amblyopia. Now, what is sensory deprivation amblyopia? The sensory stimulus to one eye itself is less because of something blocking the light rays. Example, any congenital cataract, traumatic cataract, any corneal opacity, ptosis. Let's say the eyelid is always closed in one eye, then obviously the visual input itself is less, the sensory stimulus itself is less. So ptosis. So this is sensory deprivation leading to form deprivation amblyopia. Isoametropic amblyopia is when both the eyes bilaterally high degree of uncorrected refractory error. So refractory error bilaterally high degree and uncorrected, 6 diopters, 7 diopters, etc. Then you have meridional amblyopia. Now what is meridional amblyopia? Similarly, where you have one eye will have high degree of uncorrected astigmatism. So that is lead to meridional amblyopia. So just remember the subtypes names and just 1-2 words enough. So that is about form deprivation amblyopia. So strabismic, most common, second most common refractory or anisometric, irreversible organic, and then rarest with poor prognosis is form deprivation, under which you have sensory deprivation, meridional, and isoametropic. Next, coming to the treatment. Now, as I told, it is reversible only if you start treating at an early age. During the critical period, you should detect it and you should start treating immediately. But before that, you have to, any correctable cause of amblyopia, you have to correct it. Like if there is any refractive error, you have to correct it. If there is any corneal opacity, you have to surgically remove it. If there is any cataract, you have to surgically remove it. See, corneal transplant for corneal opacity, surgically remove any cataract, etc. That you have to do. Then, treatment modalities, there are various. Gold standard is occlusion therapy. Now, what is occlusion therapy? Think about it. Occlusion therapy, we occlude one of the eyes. Which eye do we think we block? We occlude the sound eye. Why do we occlude the sound eye? So that the weak eye, the visual cortex is now forced, it has no other choice but to utilize the visual input from the weak eye or the amblyopic eye. So it is forced to use the input from the weak eye. So how do we occlude the sound eye? Here you can see an adhesive patch in this picture. You can also put a gauze pad and stick it with tape. You can use opaque contact lens, etc. Now, under this occlusion therapy, there are various types. First of all, we have full-time occlusion therapy, where all waking hours, of course, when you're sleeping, you won't occlude it because you're anyways shutting your eyes and sleeping, right? But all waking hours is full-time occlusion therapy. Now, 2 years of age, up to 2 years of age, you'll occlude the sound eye for 2 days and then the amblyopic eye also for 1 day. 3 years of age, 3 is to 1. 3 days sound eye, 1 day amblyopic eye. 4 years of age, 4 is to 1. 4 years, 4 days sound eye, and then 1 day amblyopic eye. Now, why are we doing this? Why are we also occluding the amblyopic eye? Because let's say we keep the sound eye occluded for a long time. Then what happens? Okay, the amblyopic eye is not, the visual cortex is being forced to use visual input from the amblyopic eye. But what about the sound eye? Sound eye will now go into amblyopia. So to prevent occlusion amblyopia of sound eye, we also occlude the amblyopic eye for small durations so that this sound eye does not go into occlusion amblyopia. Now that is full-time occlusion therapy where all waking hours we occlude. Now there is another one known as part-time occlusion therapy. Now this part-time occlusion therapy, we occlude only for 4 to 6 waking hours. Not throughout the day, but 4 to 6 waking hours. And it has been found that it is equally efficacious, meaning it is not inferior. So obviously we'll prefer part-time occlusion therapy, more patient compliance, and also lesser chance of occlusion amblyopia. Now, till when will you keep doing this? Will you make the patient wear an occlusion patch throughout his life? No. Until the amblyopic eye, see, when we're doing this, eventually the amblyopic eye visual acuity will keep on increasing, right? So we'll keep doing this until the visual acuity in the amblyopia eye becomes equal to that of sound eye or as much improvement as possible until it stops improving. We keep on doing this and then we stop. And then we stop. Do we permanently stop? Now let's say 6 years old child, now it became equal. Do you stop? No. We do maintenance occlusion therapy for 2 hours every day. Now, what is this maintenance occlusion therapy? We do this so that until 8, I told you, right, critical period is from birth to 8 years old. So, till then, there is neuroretinal plasticity. So, amblyopia may recur. So, to prevent recurrence, we occlude it daily for 2 hours until 8 years old. Now, one big disadvantage of occlusion therapy, what do you think? Do you think children will wear those adhesive patches or those gauze pad and tape for throughout the day? No, children usually don't want that irritation, right? So there's a high chance of non-compliance. Then we go to something known as penalization therapy. Now, what is penalization therapy? Here it can be optical penalization or pharmacological penalization. In optical penalization, as you can see in this picture, the child is made to wear spectacles where one lens of the spectacles is opaque and the other one is transparent, so that the transparent side is on the side of the amblyopic eye and you're forced to use the amblyopic eye. Now, of course, the disadvantage of this is cosmetic value is decreased. The child might get bullied at school or something. Then pharmacological penalization is atropine eye drops. So atropine eye drops, what do you do? The atropine eye drops, when we put atropine eye drops on the sound eye, the sound eye will go into cycloplegia. So there'll be blurring of vision in the sound eye. But what is the biggest disadvantage of this? Number one, drugs. And adverse effects. Atropine will have other adverse effects like dry mouth, etc., which you're making the child forcefully undergo. So that is the disadvantage of pharmacological penalization. Now, apart from this, you have various adjunctive therapies like perceptual learning, where through visual stimulus you'll make the child learn, computerized home vision therapy, iPad-based video games, where you're forcing the child to, where not forcing exactly, the child will also enjoy it and they can, both their eyes are getting stimulated, they're moving from one stimulus to another, so it will help them develop their vision. And then pleoptic exercises will correct eccentric fixation to foveal fixation. That is, instead of light rays being focused on the peripheral parts of retina, it will get focused on the fovea where you have maximum visual acuity. So these are certain adjunctive therapies, but gold standard is occlusion therapy. If non-compliant, then you can go to penalization therapy. So that is it for amblyopia. I hope you guys enjoyed the video. Thank you for watching.